hypertensive crisis, the end result of the worst case scenario of hypertension, right? Because you know there's always has to be some bad thing, because we talked about stable angina and NP2, so now we got to talk about, and we talked about a little bit about hypertension in that class as well, so now we talk about hypertensive crisis. And then we talk about heart failure. Heart failure has kind of a two-pronged approach. Sometimes your patient has heart failure because of uncontrolled things, because it can be something that happens with poorly controlled hypertension for years and years. Hearts get bigger, start to change the chambers in the heart, it doesn't pump efficiently. It can happen as a result of a patient having a heart attack. The muscle is not perfused, it gets weaker, not able to pump efficiently. Can be secondary to other types of disorders, kidney disease. You know, so different things that can happen for as far as the patient having these issues, but basically what it is the body's not able to perfuse because it's not able to pump. Okay, so the worst case scenario for that is going to be the cardiogenic shock. Okay. Now cardiogenic shock looks like all your, you know, shock states we kind of talk about as we go along in different things, but this is also one, when you talk about cardiogenic shock, where you actually have to do things a little bit different because pulse rate goes up, but their blood pressure, when you talk about late, actually goes up as well, which is not something you normally see. And also, these people don't get a lot of fluids. Because remember, their heart can't pump efficiently in the first place. So they're going to get some, but not as much. Because most things, when you overall shock states, the thing to remember is most people are going to need fluids. Some need a lot more than others. Hypovolemic is going to need a lot. That's the person that's going to need a lot of fluids because remember their vascular volume is gone. Cardiogenic, because my heart can't pump efficiently, I'm going to need it, but I don't need as much. Neurogenic don't need a whole lot at all because neurogenic actually causes vasodilatation. So if you gave them a lot of fluid, it just sit there because there's no tonicity in the vascular system. So essentially they drown in their own secretions. So it's little different things that make it a little, nuances make it a little bit different, but we'll get through that. But this is where you need to concentrate your information on. So then we'll talk about how it's detected, what kind of things we see in the patient, how do we manage them, and of course if you notice the medications are the same. Because pretty much you just use one for a different thing in a patient. Okay? And then we're also going to talk about the other medication that should go up here with those are going to be your, especially with heart failures, because that's now considered the standard of care and treatment with patients, is that patient's going to go on an ACE inhibitor. Because they stop ventricular clotting or stop that process from getting worse in a patient. So even if blood pressure is low, patients get the medication. You just give them a lower dose. Okay, you ever notice why you see some people taking 25 milligrams of one drug and other people taking 3.25? Because Corig is one of those. It's a beta blocker. But the thing about it is the dose is different based on what the patient needs it for. So those kind of things you're going to see in your patients. So we also look at BUN and creatinine because one of the things when the body doesn't perfuse itself, it doesn't perfuse important organs. And if you notice your patients who have heart failure, this week when you go in the hospital, think about looking at their labs. If you notice their BUNs are a little bit higher, their creatinines are a little bit higher. Renal insufficiency is something that you start to see in patients. And it gets worse over time. So that's something that you got to monitor because you have to change medications and that kind of stuff based on what's happening with your patient. But this page will give you what you need to focus on for content. Okay, because this is where it is. All right. You feel a little better now, Ron? All right, because it is a lot. When you look at the cardiac chapters, there's like 6, 7, 8 chapters in the book. So you're going like, how am I going to figure out which of those things I need to look at? This is the snapshot of where you're going. And then, like I said, I made copies of that chapter in the book or a couple of chapters, because it kind of shows you the correlation between how do you look at those things together. Not saying you got to use it, but it's just one of those options you have there for you. All right. So now we're going to talk a little bit about structures and functions. And since electricity was our first thing over there, we'll start with electricity today. But you got to kind of think about what do I see and what's going on with the heart. Okay? So we got to look at the chambers. You know, the upper chambers are your atria. Lower chambers are ventricles. Okay, the ventricles are the parts that pump out things to either the periphery or to the lungs. You got to think about what's going on with your patient. Right? So when you're thinking about these, the atrial are lower pressure chambers, the ventricles are your high pressure chambers. The left ventricle has the most pressure to overcome, because that's what's going to pump out to your fingers and toes. So it has to get out to everywhere in the body. That's why left ventricular problems are a big issue when a patient has a problem. Okay, because the left ventricle isn't working, you start to see symptoms in your patient pretty early. Okay, about things that have happened with your patient. Then you got to think about the valves. The atrioventricular valves are those valves which separate the atria from the ventricles. And then you have your other valves, your semilunar valves, which actually go out to the other parts of the body. So they're going to be things that we look at for your patient. And which valve are you going to be looking at for disease process? Mitral. Because that's the one where you have disease happen most often. And then we have layers, because that also kind of affects what you're thinking about, what's happening with the patient. Pericarditis is that outer covering of the heart. Anything that moves on itself or that moves in the body has to have a visceral layer and a parietal layer. And in between that is going to be some fluid. So that's the pericardial fluid that you see in that area. That allows the heart to actually move and not get stuck, per se. But the pericardium is that outer sac that covers it. Then you have the myocardium, which is the muscle layer. It's going to be thickest in the left ventricle because it has the most pressure to overcome. Okay, so that's where you see muscle layer the thickest. And then you have the endocardium, which is the inside. That's going to line the chambers, covers the valves. So you can think about when you're talking about disease, where it's located, think about structures. Now on the venous side of it, arterial side, they actually have the same layers. It's just that if you look at the arterial system, the media is larger because it has to expand and contract based on the needs of your body. The venous side is going to be thinner. Okay. So adventitious is the outside. The media is the muscle layer that changes based on the pressure, all those types of things. And the intima is the innermost lining. So that's where the fatty streaks attach. That's what they're looking at when we talk about homocysteine levels, to see if we can talk about changing your lifestyle, CRPs, all that kind of stuff that we're looking for to make some changes in what's going on with patients. That's where the intima, the inside part of it. Okay. The conduction system, because we're going to get all into this now. The conduction system kind of tells you what's happening with the heart as far as the electrical system goes. And the test that you use for that, what we use most often, is the EKG. EKG is going to tell you that it's going everywhere it's supposed to go. Okay. So when they tell you things and you're listening to a report, if somebody says a patient has a sinus rhythm, it means it starts in the SA node, goes to the AV node where it's supposed to, bundle of His, okay, right and left bundle branches, because you got to go on both chambers of the both ventricles to the Purkinje fibers. That's the electrical movement. So SA node, AV node, bundle of His, right and left bundle branches, Purkinje fibers, and that produces the EKG rhythm. Okay. So atrial depolarization, that part about that first that says the atria are contracting, is going to be your P wave. Okay, so that's what that P wave stands for. That's going to be atrial depolarization, meaning that the atria have contracted. Okay. The QRS complex is going to be your ventricles. Okay, so that tells you that the impulse has now gone to the ventricles, goes where it's supposed to. Now the thing that Veronica got into was saying that how many boxes are each one supposed to be. I'm not going to ask you on the test. But just so you know, in your head, because the thing about it is when you leave here, you're not going to be a person that has to do leads and monitors all the time. Just know it should be narrow. QRS complex should be narrow all the time. So it should be no more than 3 boxes, 0.12. That's what she was looking at. You know how many boxes are there. So when you start to see them wide tells you bad. Okay, so always think wide head, wide QRS complex, I call it the witch hat. So if the witch's hat gets bigger, then something is wrong with the ventricles, which are the things that kill you. Okay, atrial stuff, and when patients have atrial rhythms, patient feels bad for a while, they can deal with that. But ventricular stuff can kill you now, kind of thing. That's why you address those things, or that's why those are rhythms you got to know. Okay, so atrial stuff, you feel bad, patients say, oh, my heart's beating out of my chest, they may have syncope, all bad things. But ventricular stuff will take you out. Okay, so that's why you have to address those. So QRS complex is ventricular depolarization. The T wave is going to be ventricular repolarization, where the heart gets ready to beat again. Nothing ever in life should happen on a T wave. That's very bad. That's the worst case scenario when you have QRS complex getting wider, tells you heart is irritable. But when things happen on a T wave, it puts you into lethal arrhythmias. So when you hear people talk about patient had Q on T, that's very bad. Okay? Because the T wave is when nothing should happen. This goes back to your A&P class. Remember that sodium potassium pump? Where you have things that stuff moves in and out of the cells, causes contraction, and then you go back to a steady state. The T wave is essentially the steady state for the heart. So nothing should be happening on the T wave, ever. Okay. Very bad stuff happens to a patient when you see that. Okay. So that's the conduction system that you're looking at for your patient. Now when they say something is sinus, meaning it starts and ends where it's supposed to. Okay. If you already know, you don't think you know. Well, and others. You know some of them already. Sinus rhythm tells you the heart rate is in normal rate. So what's the rate?
60 to 100.
60 to 100. Sinus Brady?
Below 60.
Below 60. Sinus tachycardia?
Above 100.
Above 100. You got 3 of them already. All right? That's all they're when they're talking about sinus stuff. When they tell you a rhythm is when they've used that first part of it to tell you where it originates. So atrial fibrillation tells you where is it happening? In the atrium. Ventricular fibrillation tells you it's happening in the ventricle. So that's what they're talking about. They identify what's happening with your patient. Okay? Now, when they talk about, which you didn't have to know, the blocks part of it, tells you that there's some problem in conduction. Okay, so it takes longer and longer for the impulse to get around to where it is, because what's going to change is those boxes. Okay? So when you're talking about the heart blocks, it has to do with the P wave, the PR interval, but it gets longer and longer till you drop one. Okay, that's how, because people always go like, what does that mean? I always describe it like a relationship. Okay. You're at home, everything's great, fantastic, you're in love, life is great. Y'all get together, eat dinner all the time, life is wonderful. Okay. So one of you is mad because of something. Okay, so then you decide I'm going to stay out a little bit longer. So that PR interval gets a little bit longer. All right, so that's your relationship. It's great, but all of a sudden, because you don't wash dishes, and you always leave them for me to wash, I'm going to wait a little bit longer and see if you're going to wash them. Okay, so that's when you're talking about, that's first degree. PR interval gets a little bit longer. Okay, then type 2 block has 2 different things going on, because it's weird. Okay, so you have a progressive lengthening of the PR, because you know, I stayed off longer, you're still not washing dishes, so I'm going to stay out even longer, kind of thing. We'll see if you're going to wash them, because I refuse. You know how we are. Because we do that. We do those kind of things, right? I'll stay out a little bit longer and leave them in there. Hopefully no roaches come, that kind of thing. But you know, you stay out a little bit longer, that kind of thing. And then one time, because that's happening at, you talked about type 1, then type 2 is that you're going to see it get longer and longer until you don't come home at night. Then you know you start getting, you got to put it back. You got to fight folk then. What you mean you got coming home at night? Kind of stuff. All right? That's winky bob. Okay, think about it. It gets longer and longer, progressive, until you don't have a QRS complex, because that's essentially what happens. The PR interval gets longer. It gets longer. So instead of coming home at 6, you come home at 7. Then the next week you come home at 7:30. The next week you come home at 8. Then you say, I ain't coming home at all. But your PR interval stays long, but you drop the impulse. So that's winky bob. Okay? And if you think about it, you wink, something disappears. So that's how you think about it. The QRS complex is going to disappear. In 3rd degree, y'all living in the same house and y'all just doing your own thing. Because the atria are beating to their own beat. The ventricle are beating to their own beat. But if you actually took out calipers, they measure exactly the same. The QRS complexes are equally apart. The PR intervals are equally apart. But they're not working together. That means that you can't do any cardiac output. Y'all not working together at all. Your house is a hot mess, kind of thing. So 3rd degree heart block, a complete heart block, means y'all, the atria and ventricles are working totally separate ways. I got to fix that, because I need blood to flow from one to the other and keep going to the rest of the body, and that's not happening when you have a person that has complete heart block. So that's when we get into putting pacers and all that kind of stuff.
So we need
figure
to know
out
about
what.
that, right?
Huh?
We need to know that.
No, I'm just telling you. That's the easy way to learn them.
Okay.
All right. That's just it. Those are the major ones. Now, when they talk about SVT and all that kind of stuff, just tells you something that's happening outside the normal pathway. SVT is a type of ventricular tachycardia, a supraventricular tachycardia, but it's a narrow complex tachycardia, whereas VTach is wide. That's how you tell the difference. It's something that's happening in the ventricles, but it's a narrow complex. When the patient has VTach, it's a wide hat. The witch hat is big. Okay. So I'm gonna draw some pictures up here so you can see that. Because those, the rhythm ones, or the ones you have to know, are going to be atrial fibrillation, VTach, VFib. Okay. So atrial fibrillation first. Start talking about electricity. So you know it's involving the atria. Fibrillation just kind of tells you, just fibrillating there. So the heart is quivering, but it's just the atria that are doing it. Okay. So your atrial rate can be as high as 400. Can anybody sustain that for a long time? No. Most patients who are diagnosed with AFib don't have a rate that high when you talk about the ventricular rate. But if you looked at the atrial rate, all you see is, you can see a heart rate as high as 400. Now the thing about it, instead of producing that nice pretty PR, you're going to have fibrillation waves. So they don't have a PR interval. You know how normally you would see this? Because that's the P wave. Instead of a P wave, you're going to have that. And then you have a QRS complex. And then you're irregular, so you're going to keep doing that. That's the reason why you have to listen to a person who has AFib for a full minute. If the heart rhythm is not regular, you can have somebody that has a beat now, and may have one 10 seconds later, and then they'll do 10 more, and then they'll slow down again. Atrial fibrillation, you have to listen for the full minute because of that, because it is totally irregular. So no distinctive P wave is significant. That's something to remember for testing purposes whenever it happens. I don't know when it's going to be. All right? Because you have, that's one of those things that kind of makes it significant. So there's no P wave that I can discern. It's an irregular QRS pattern. So if I took out calipers, there's nothing that's going to tell me that's going to be regular. Because when we're doing calipers, we're seeing that everything equally spaced from each other. So there's irregular QRS complex. Okay? So atrial fibrillation, okay, is always something we got to treat. Because that quivering, that momentary pooling that goes on in the heart can cause clots. So that's what the big issue is when you talk about atrial fibrillation. So always have to treat it. One of the things you got to remember for life, atrial fibrillation of unknown duration is always going to be anticoagulated. Because I don't know how long this person had it. So that means I need to anticoagulate this person. Before I try to fix this heart rhythm, I need to anticoagulate the patient first. Just because that's one of those things. You can't let it go and go like, oh, I'll fix the rhythm first. If you fix the rhythm, heart gets a good coordinated beat, you are going to cause an embolic shock in the patient. Okay, so atrial fibrillation, unknown duration, always anticoagulated first. Okay, so whatever the doctor is going to use to anticoagulate the patient, and we know in the hospital the fastest way to get there is heparin. So that's why you see patients do that. Because I can do that within hours. I can achieve anticoagulation within hours. Then I can talk about doing some other thing. Now the patient's going to go on medication, don't get me wrong. We're going to give them medication to try to correct the rhythm as well, but I got to get those clots. That's what I don't want to happen in my patient. Okay, so diagnostic testing, when you think about this, is going to be an EKG for one, because I need to see this in a patient. So they're going to have a 12 lead. Okay. If I suspect this person has something going on, you may also see a transesophageal echo done on the patient. A little bit different from the regular echo, because echo is going to take pictures of the heart, but why they do it transesophageal, meaning they're going to put a probe down in the esophagus to look at the heart from the back, is to see whether there's clots in the chambers. That's big time important if you're thinking about doing a cardioversion on this patient to correct the rhythm. Okay, so I want to make sure there's not a big old clot sitting back there that once I get you back to normal, it's going to push it out and block something off. Okay, so I can see that happen in my patient. Okay. The other thing they're going to do is also test the patient's thyroid function, because sometimes if you have a patient that's hyperthyroid, it produces atrial fibrillation in a patient. So if it's a brand new atrial fib, that's what you usually see done for the patient. They're going to look at other stuff, but those are the big ones that you're going to see in the patient. Now, if I'm going to correct this, like I said, I'm going to anticoagulate the patient first. And then, of course, we get into if it's non-valvular AFib, because there are some criteria, not that you got to know all of those, but know that they choose the medication based on why the patient has it. If you have valvular or if a valve problem is causing your AFib, you cannot use these new drugs because it's not proven yet that that's okay. If it's valvular associated AFib, those people go on Coumadin. They always do. Those new things like Eliquis and all that kind of stuff, it has to be for a specific reason. You can use them, but it has to be non-valvular AFib. So I see this happening in my patient. I anticoagulate them. Medications that we can use to kind of convert this to slow down the rhythm, the drug that you see most often is cardizem. Cardizem can be given in an IV, so a patient usually gets a bolus. Then I can start the patient on a drip. Cardizem also comes in a pill, so they can take it when they go home. There's the extended release form, Cardizem CD. And what do we know about those CDs, XL, ERs, all that kind of stuff? What shouldn't you do? Crush them, because you get rid of the effect that you want to have for the patient. But cardizem is a calcium channel blocker. So what do you got to worry about? What can it do? Huh? It can lower your blood pressure. And maybe you got to think about what the drugs do. Cardizem is a drug we can use for this because we can use that for the immediate period and usually see it with the diagnosis of a patient who comes in the hospital that says atrial fib with RVR. When they say RVR, that's rapid ventricular response. Those are heart rates that are usually 140s, 150s. If it's a slow AFib, meaning that the ventricular rate is between 60, I should say 60. If it's just regular, I should say regular old AFib. All right, regular AFib means the ventricular rate is 60 to 100. Those people are usually asymptomatic. If it's a slow AFib, meaning the heart rate is less than 60, which would be like a bradycardia, that's usually the syncope person. So that you can pick up on why the person has or what's going on with their AFib. Just most people who have AFib, if their heart rate is between 60 and 100, are asymptomatic. Those are the people that find out because you just happen to do an EKG. If it's a low ventricular rate, meaning that, yeah, your atrial rate is 400, but I only get, if I actually felt the pulse or I listened to you, your heart rate is only 40. That's a slow AFib. That's the person that usually has syncope. If you have a person whose ventricular rate is greater than 100, that's usually the person having palpitations. They'll tell you it feels like my heart's beating out of my chest. That's the kind of thing. You can pick up why they have their, what their rate is like from AFib, just talking about symptoms the patient has. Or feels like I have fluttering in my chest. That's what they'll tell you. Those are the kind of things you look at for that patient. Okay, so cardizem is the medicine we can use, calcium channel blocker. So I got to look at blood pressure. Can also make heart failure worse. Remember, because calcium channel blockers can make you hold on to fluid. So you got to listen for crackles in the lungs, peripheral edema. Those types of things happen with your patient. We don't have that happen a lot associated with it, but it can happen with your patient. Now, if they were going home on cardizem, what else do I have to tell them about food? No grapefruit or grapefruit juice. That's that pill. They want it all the time because they come to Florida. When you have these little old people falling out when they come down here, it's because they now go out and get a grapefruit off the tree and are taking Norvasc for their blood pressure because it's a calcium channel blocker. Okay, so it's going to slow your heart rate, slows nodal conduction. Sometimes the patient will convert just using medication. So it's going to be the first line drug we use. If you got a person who keeps coming in with AFib bouts, you start seeing other drugs. I will tell you that because sometimes you're like, how come this patient is in AFib and they're not using this one? It's because they fail on this one. Because it's the one by far that has the less stuff go wrong with patients when you give it. The other one that you might see is amiodarone.